Hello, everyone. Hello, everyone. Welcome to this Nest 360 UNICEF Newborn Toolkit Joint Learning Community. And we hope that you are safe where you're sitting. And the purpose of this series is to encourage collaborative learnings for advancement of small and sick newborn care. So these seminar series are usually structured as per health system building blocks linked to the Nest 360 and UNICEF and Newborn Toolkit. Please don't miss to learn more on this toolkit through the link provided, but also subscribe to the newsletter to learn more on the toolkit. Without missing more on this interactive series, please do click the translation button. This is our first implementation toolkit seminar, live translated into French. So please don't miss the discussion. Do subscribe and click for your French translation. With this, today we'll be having a series of panelist experts taking us through the title of our seminar series today is After Discharge from Small and Sick Newborn Care, What Care is Needed and How. And without taking more time, I would like to introduce myself and the next speaker. So my name is Nahia Salim, a pediatrician and senior lecturer at Muhimbili University of Health and Allied Sciences, working very closely with Ifakara Health Institute in Dar es Salaam, Tanzania. The first speaker will be Dr. Louise Tina Day from London School of Hygiene and Tropical Medicine, taking us through an overview of nurturing care after neonatal discharge. And please, to all speakers, feel free to introduce yourself before you start. And every speaker will be inviting the next one so that we save time and have more time for question and answers and interactions. Dr. Louise Tina Day, please, welcome.
Thanks so much, Naya, and warm welcome to everyone from me as well. Next slide, please. I'm presenting today this overview, next slide, please, on behalf of Bernadette Delman and Sheila Manji from the Department of Maternal, Newborn, Child and Adolescent Health and Aging at WHO or MCA, and also Ornella and myself. And we've framed it around this thematic brief that was published in 2021, and the links on the slide. And it'd be great, Toby, if you could kindly pop that in the chat. Next slide, please. So the thematic brief really focuses on that nurturing care continuum during inpatient care and linking to after discharge, and of course starting before the baby even gets admitted. And I think certainly from my own experience, it's the one question that's on every parent's mind when their child is sick enough to need admitting is how soon will they be better and when can we go home? So it's a really important that we think about that continuum as we care for children when they're admitted towards discharge. Next slide, please. So I'm going to do two things. Firstly, talk about what is nurturing care for every newborn, and then secondly, think about how to create those nurturing environments for newborns after discharge. Next slide. So firstly, what is nurturing care for every newborn? Next slide. Well, it goes without saying for everyone who's joined the call today that it's important. It matters. It's a once in a lifetime opportunity that newborn babies are cared for in that nurturing environment so that they not only survive, but are also helped to thrive. And it doesn't just benefit the newborn, but it benefits their family and the whole community. And so we're going to think about that continuum, that nurturing care continuum, particularly focusing on the during inpatient and then after discharge. Next slide, please. Nurturing care has 5 components shown here, and we link each of those components. These components go beyond the newborn period, but here we link it with that first month of life. So good health is about preventing and managing illness, including provision of evidence-based high quality care. Adequate nutrition means optimizing exclusive breastfeeding or breast milk feeding. And all of that's important for every newborn and also for those that are small or sick and need inpatient care. For safety and security for newborns, that means warmth, good hygiene, minimizing stress, and enabling the primary caregiver, most commonly the mother, to be with her infant in a quiet environment. That opportunities for early learning begin in the newborn period, stimulating the baby's brain gently, touch, voice, or close contact. And then responsive caregiving, aware of the newborn's signals, indicating readiness for feed, pain, or stress, and responding appropriately. Next slide, please. We use the infant and family-centered developmental care as our model in the thematic brief, based on the principles of dignity and respect, information sharing, participation, and collaboration. And starting with that mindset when before birth, during the time in hospital, in the health facility, and then linking that to that after discharge piece is all important. It's the same principles, on that continuum. Next slide, please. When we dig down a little bit into what are the components of infant and family-centered developmental care, they're shown on this this flower graphic. And again, each one is important during admission and also after discharge, but particularly just focusing on the ones after discharge. So for the first one, creating a nurturing environment for all newborns. And you can see the 5th bullet point is about continuing that into postnatal care after discharge. For the second green bullet point, nurturing care for small and sick newborns. Again, it's thinking about that, that starting zero separation during admission and then promoting it after discharge. And then for strengthening the health system, the 4th bullet point is thinking about what follow-up care as this individual baby will benefit from after they go home. Next slide, please. So secondly, how can we create those nurturing environments? Next slide. Thank you. So again, in the thematic brief, we have this figure, which is adapted from the European Foundation for the Care of Newborn Infants. And you can see the top banner, the top panel, education and training for infant and family-centered developmental care, means that every person in your team understands the importance of that family-centered care principle, infant and family-centered care principle. And then there are 8 standards, the way this graphic is showing, which each one is important during admission, but also similar are needed after discharge. And then the bottom banner, case management and transition to home, just shows how important this post-discharge thinking really is in order to build that continuity of care for the infant. Next slide, please. So let's spend a little bit of time thinking about what can facilitate a smooth transition. So if the family are involved with the care during admission, then they build those skills and confidence which can equip them to carry on providing that care after discharge. But each baby is an individual with their own particular needs, and so it's important that we think about that individual baby and their follow-up, what if they might need investigations or procedures, in collaboration with the parents, so shared decision making, and also our primary healthcare providers in the community. And before discharge, parents need to feel confident that they can provide the routine continuing care, even though they're desperate to go home. It's very different when you're suddenly at home and you're the person who has all that responsibility. So we just need to have those conversations about, are you ready? Do you feel confident? Are you going to have the necessary support? Because that family support is crucial. It's a big job looking after a baby, especially if they've been sick and needed admission and then they're being discharged. So we need to think about that support structure around the family, around the mum, around the father, and in order to provide that well. Next slide, please. So in 2023, a very important series was published in The Lancet on breastfeeding, and I'm sure we've all been reading it and learning from it. And my own personal practice was to ask the mum, okay, you're doing really well with the breastfeeding, but when you go home and people start saying, oh, your baby's very little, your baby should be growing more quickly, why don't you give extra feeds? I used to say to them, what will you say when you when you get asked that question. And you could see from the mum's reaction whether or not she said, I'll tell them my milk's enough, or, oh yeah, if they sort of pondered, because I think that's what we're sending them out into, is this very, you know, sometimes quite aggressive marketing around commercial milk formulas and so on. So we have to, it's one of the other places we need to ensure that our mums are ready and fathers are ready for, as they discharge. They're just preparing for that environment where they'll be pushed and pulled into maybe not kind of losing that confidence that their milk is enough. And this is very interesting, that misreading those cues of a baby crying means they're hungry, which is what's often thought, is one of the big drivers for that self-reported insufficient milk. So yeah, helping to understand the baby crying isn't only saying that they're hungry is really, really important. Next slide, please. This is a quote from a colleague who also was involved in writing the brief with us, from Sweden, Ilva. And I really think this is very wise. What you do often, you become good at. So if we often are thinking about preparing families for discharge and you know, talking about all those different aspects of care, then we become good at it. And this doesn't matter, this is across wherever you are in the world, whether you're in Sweden, but also these pictures here are from Lebanon and from Africa. So yeah, I think that was very wise advice. What you do often, you become good at, both during admission, but also becoming good at preparing for discharge. Next slide, please. So in the brief, there are some nice country examples of how in these settings, inpatient care leads to nurturing care after discharge. And I know we're going to hear from lots of other colleagues on the call today, but here are some other examples within that thematic brief for your information. Next slide, please. And also just wanted to highlight some other resources that you may find helpful. There's a whole document sharing the resources that are available. And if you look at the green concentric circles on the right, nurturing care includes enabling policies, supportive services, empowered communities, and caregivers' capabilities. So thinking across all those interdisciplinary areas. So really provide a comprehensive approach to nurturing care. Next slide, please. And then there's this practice guide, which is a really helpful resource. We've just highlighted here a few parts that really relate to post-discharge nurturing care, again about planning that we've already talked about. And then those questions in bold, inquiring of caregivers. Have you learnt the skills that you feel you need? You know, the child is going to carry on learning new skills and at different levels of energy depending on how quickly they're recovering from whatever their admission was. And then, you know, practical, what will you be able to do? When will you be able to do it? So when you get home, it's very easy to get busy, and just really having those plans in place are important. And then really importantly, in the box at the bottom, supporting caregiver well-being. As I've already alluded to, it's stressful, very stressful having a sick child admitted. And then after discharge, that tiredness really sets in, and as we've said, the only caregiver. So some practical questions to support caregiver well-being. Next slide, please. There are lots of things we don't know how best to do. I've just highlighted 3 of them here. How to improve zero separation during the facility to improve that discharge preparedness. There's a recent paper published that indicates that in India, Malawi, and Tanzania, mother-infant diets spent more than 1/3 of their admission separate. The second bullet point, how to support caregiver postnatal neonatal education. A couple of references there, just saying that we're not we know it's important, but how to do it in the most effective way, we still need to generate evidence around. And then importantly, the last one, it's just those linkages from health and nutrition. We know that children that are discharged, newborns that are discharged are vulnerable, particularly for nutrition and becoming malnourished. So yeah, I put a link there about the management of small and nutritionally at-risk MAMI resources that, you know, really are very nice holistic resources thinking about caregiver well-being as well as illness and nutrition. Next slide, please. So in these few minutes, we've just touched on what is nurturing care for every newborn, how to create nurturing environments for newborns after discharge. Next slide, please. And I'm just going to finish with this slide just once again, as I know everyone on the call believes that nurturing care for newborn matters. It's a once in a lifetime opportunity to help newborns survive and thrive, benefiting both the newborn, their family and the community along that nurturing care continuum. Next slide. So thank you very much. And I'd like to pass now to Dr. Vivek. Over to you.
Thank you, Louise. And can someone confirm if my slides are visible?
Yes. Right, we can see them.
Perfect. Thanks to the Next 360 team as well. And this is such a good segue into the 8 minutes that I'll try to talk about the India program. And I'm Vivek Virendra Singh. I work as a health specialist with the UNICEF's India country team, and I'm currently also officiating for my team's lead, the Chief of Health for UNICEF. And I also manage the newborn portfolio within the team here in India. So in these next 8 minutes, from understanding what is the nurturing care framework and how that continuum is important, we'll try and see that some of the steps a country takes in terms of trying to operationalize this into programming. A quick understanding of where we stand when it comes to newborn mortality in India. And this is just to show the diversity that we have. We have a state with a newborn mortality rate of 2, and we have a state with newborn mortality rate of 32 per 1,000. And that's the diversity in terms of system capacity. Numbers, we have 27 million birth cohort. So that's the birth cohort we are looking at. And we can see these trends towards the SDG goal of different states in the country and how they actually represent different continents and groups of countries, I would say, across the world. We all know the major causes, and the reason why this is important is that for children, not just to survive and to thrive, as Louis has very rightly mentioned. So now as countries' capacity to work on these survival issues is improving across many state systems, countries trying to focus on the thrive component of it. And that is where, in response to its global call for the Every Newborn Action Plan, when India did its India Newborn Action Plan, there was the 6th pillar, as you would notice to the right on this slide, of care beyond survival. So starting from preconception and antenatal care, the 5 key strategic intervention areas, but India specifically emphasized on the 6th one, which is care beyond survival. And that's where most of its, not just the post-discharge, but also high-risk newborns that are delivered at home or who have never come to the facility is also managed. So just to give a sense of when we say post-discharge, from all the labor rooms and also the special newborn care units, the program scale is currently, the footfall is 1.2 million babies are discharged every year, and they're all having medical records in a special MIS. There are about 1,000 special newborn care units with bed strength from 30 to 60 across 750 districts. Who gets followed up after newborn care? So essentially through the continuum, it is this 1.2 million SNCU discharged babies, then low birth weight and preterm newborns who did not require SNCU admission for some reason or were missed, went directly back home. Facility and community-based newborn screening for 4 diseases, that is developmental delays, defects, diseases, and nutritional deficiencies. And nutrition services, Anganwadi centers is the local language for a nutrition unit, based screening of 6 weeks to 6-year children for these 4Ds, and also linking some of these at-risk children beyond this age. So school-based screening from 6 to 18, where also there's some guidances for high-risk babies. So if we look through the continuum of care, it is this facility-based follow-up care through SNCU online monitoring system, where at-risk babies are post-discharge. They're also given some social security to come back for follow-up to the facilities. Then there is this home-based newborn care. And through the continuum, home-based young child care, which will go for the nutrition interventions and continued early childhood development capacity for the caregivers, family, as well as frontline workers. And then we have the Rashtriya Bal Swasthya Karyakram, which in the local language means wellness program for the children, which extends from the birth to 18 years. And the school is the main platform through which it is delivered. Now, what is done is that with these SNCU discharged babies, what is done is that they are followed up at the facility using the SNCU MIS data for looking at the risk profile of the babies. So let's say here, if 79% in one of the states, SNCU newborns received at least one follow-up at the facility post their discharge, this is the kind of follow-up information which is available. And at the time of registration, these kids and their families are linked to a phone number where the facilities are also able to follow up. Although when we follow up from the MIS, the proportion of these kids coming to the facility for a post-discharge follow-up or at home is about 1/3 to 1/4 kids being regularly followed up. And for others, we have done some inquiry where most of the time when the kids start getting well, they are lost to follow up and they stop responding. And in some cases, it could be lack of resources for access. So that is where the states try to work. Now, if we look at the program portfolio for the newborn care in the country for the last decade, health system contacts till 1.5 years is about 30 times health system comes in contact with a child up to 1.5 years. So there are about home visits 6 to 7 in the newborn period, and facility follow-up for these vulnerable newborns, 5 facility follow-ups for which their families also get money and also incentives to the frontline workers. So these facility follow-ups for SNCU discharges, if you add these, about 12. And then for at-risk, there are additional visits up to the 6 months where there is the possibility of growth faltering. And these additional home visits continue from the 3rd month to 15th month. Plus, there is this addition of at least 5 immunization contacts through village health and nutrition days. So if we add all of this, it adds to about 25 to 30 planned contacts with the health system, even if there is 50 to 60% contacts. So that's what can be achieved. Home-based newborn care, as we can see, there is guidance of visits from the 3rd day up to the 42nd day. And the frontline worker gets incentivized, and these are the services that she provides to the newborn through this program. And then there are about 1 million of these accredited social health activities which are deployed for these visits, which are 6 to 7. And the services that are provided: postpartum care, the maternal nutrition counseling, as well as through some kitchen gardens linking these mothers and families to social protection schemes. Then breastfeeding support, essential newborn care, general health and well-being, family planning, and early identification of illnesses and referral pathways for same. And some of the broad objectives also include reaching the unreached, that how these frontline workers should target the poorest, the most marginalized and vulnerable. Then how these programs are monitored. There is an information system also for the home-based newborn care. And for example, 14.5 million newborn received complete schedule of home visit. And this is the report which gets generated from the MIS, and 0.65 million sick newborns were referred to public health facility by these accredited social health activities for some issues. Then there are these guidelines for continued visits through the 1.5-year age group, so which is called the home-based young child care. There is also focus on these, for example, at-risk babies, which are now also classified as small vulnerable newborns to 1.5 years. And there is special follow-up of these kids. Then Asha, the accredited health activist checks in these additional visits for continued exclusive breastfeeding till 6 months, then complementary feeding starting, and linking it to early childhood development. There is a pictorial mother and child protection card for regular monitoring of child growth and development. And this card actually shows pictorially what are the normal milestones and what are the milestones if they get derailed, and what are the actions the families can take to bring them back as possible, and when to seek care. Child receives timely vaccination. These counselings happen throughout these visits. Age-appropriate play and communication techniques, also part of the pictorial MCP card. Then availability of ORS and IFS syrup at home, and of course, hand washing and other hygiene measures. Then age-appropriate interventions, the frontline workers are capacitated for. This home-based young child care program is now established across 90% of the districts in the country, 690 out of 750, and 4.75 million young infants received, for example, in the last quarter from the MIS report. And then this continues through the age for the 4Ds, as I had mentioned, also linking this to special screenings through the Bal Swasthya Karyakram, and these centers in every district are called district early intervention centers, where, for example, from the quarterly report, we can see children discharged from SNCUs and followed up were 0.32 million in the last quarter. Total children screened through the mobile health teams and school health platforms is 198 million. And identified with any of these 4Ds, 15.5 million. Referred to any health facility were 11.8. And secondary and tertiary care, wherever it was required, was 10.1 million. And then countries also trying to use digital technology as far as possible to try and track these at-risk newborns. For example, there is a labor room MIS, which from the labor room, from the time of delivery, starts linking the at-risk babies to the special newborn care units and beyond that. I'll just end with highlighting some of the state practices. So as I mentioned, India has states from newborn mortality, which gives an indication of their state capacity of the health system from 2 to 32. So this is an example from the state Kerala, which has newborn mortality of 2, which is now doing comprehensive screening, which includes metabolic screening, apart from the visual birth defects, to ROP screening for high-risk preterms, pulse oximetry screening, and hearing screening. And this is up to the sub-district level. So because the state now has moved much beyond with the 2 newborn mortality rate, system capacity is such. So this kind of comprehensive screening has started in these states, and about 6 states out of 29 are in a capacity that can do this and are doing this. Then in other high burden and big population states, for example, 13% low birth weight and sick newborns were identified by the frontline health workers. They were referred to the facilities. And for example, 16% of the total admissions in these special nurseries were referred from community by these frontline workers. And then they get connected through the system to the district early intervention centers, screening of children for those 4Ds, and based on their triage and priority, they get linked to various health facilities. Similarly, as I was mentioning, there is use of mobile technology and digital technology. So WhatsApp groups are then formed of families and caregivers for these special newborns, which track the visits by the frontline functionaries. And as I was saying, they're also linked right from the labor room MIS for tracking these at-risk children. Then in one of the other states, for example, I'm pointing to the right, tele-counseling manual for SNCU data entry operators for effective follow-up of SNCU discharged newborns, where they are trained how to talk to the parents to coax them, cajole them for bringing them back to the facility if they were at risk, identified at risk, and ensure that there is full follow-up visits. And then, as I was mentioning, that how to immediately start the skin-to-skin contact and early initiation of breastfeeding. So linking to various professional organizations, for example, the Pediatric Association in India has about 40,000 members. So the National Neonatology Forum also working with the private and the public sector constituents on nurturing care framework for newborns to further some of this agenda. Thank you very much. And I would now stop the screen and would hand it over to Beatrice, who will talk about hospital to home program in 3 districts of this central Uganda.
Yes, thank you, Vivek. That was so good. My name is Beatrice Nyeshaba, and I am the Research Monitoring and Evaluation Manager at Adara, Uganda. And today we are honored to have been invited to share an overview of our hospital to home program. At Adara, we believe that every woman and child deserve access to quality care, no matter where they live. For the past 25 years, we have specialized in delivering high quality healthcare to women, newborns, and children at health facilities and way back in the community. Slide 2, please. Next slide. Next slide again. Yes. Now, in 1998, we established a partnership with Chiwoko Hospital, a non-profit mission hospital in Nakaseke district of central Uganda. Together, we proudly opened the doors of the hospital's first neonatal intensive care unit in 2000, before opening an expanded NICU in 2010 to accommodate increasing admissions and save more lives. After years of continuous improvement, including investment in staff, investment in infrastructure, training and equipment, we are proud that the Ugandan Ministry of Health now recognizes Chiwoko as a center of excellence in newborn care. Next slide. Now, significant challenges exist for parents and families of high-risk infants in low-resource settings like Uganda, including lack of funds, lack of transport, and availability of NICU services. These challenges result in a number of parents not bringing their infants back for a follow-up visit. To address this identified gap, Adara and Chiwoko Hospital developed Hospital to Home, a follow-up program to support small and sick babies, both in the hospital and back at home. Next slide. Hospital to Home was developed around family-centered care. It strengthens hospital discharge processes, provides comprehensive parent education, strengthens breastfeeding practices, and promotes care that encourages healthy brain development. It also provides vigilant at-home follow-up support to families for 6 months after discharge, with a neurodevelopmental milestone checkup at 9 months. These follow-up visits are led by a network of 120 highly trained volunteer community health workers. Next slide. When a baby is being discharged from the NICU, the discharge coordinator allocates a community health worker to provide follow-up care for the baby, dependent on the location of the family. Chief community health workers are used to supervise a group of 10 to 12 community health workers within the area. and a community midwife oversees the program and provides ongoing education and supportive supervision. Next slide. In 2019, ADERA conducted a research study to evaluate the feasibility, acceptability, and early effectiveness of the hospital-at-home program. We conducted qualitative research and did in-depth interviews with caregivers and staff prior to the implementation of the hospital-at-home. And we also interviewed caregivers, staff, and community health workers after implementation of the program. These interviews were complemented with quantitative data assessing the neurodevelopment, growth, nutrition, and vaccination status at 6 months adjusted age. Next slide. Now, while the study was not powered, the quantitative data showed that the intervention cohort had 68% lower odds of any neurodevelopmental delay at 6 months adjusted age compared to the historical comparison cohort. Additionally, infants in the study who received the hospital-at-home intervention had higher reported rates of exclusive breastfeeding and complete vaccinations at 6 months adjusted age. These outcomes were exciting for us to learn, and we believe that the critical element of this program is its focus on family-centered care. I'm now going to pass to my colleague Hilda to discuss the elements of family-centered care that are part of the program and further outcomes from the study.
Thank you so much, Beatrice. Hello, everyone. My name is Hilda Namakula-Mirembe. I work with ADERA as the clinical educator. Hospital to Home focuses on engagement and education with the families, involving them in conversation regarding their baby, and encourages mothers and babies to be together as much as possible. Allowing caregivers to play a part in the care of their baby increases the baby's chance of survival and helps to build a stronger relationship between staff and caregivers. A family-centered approach to discharge planning includes a comprehensive education program that prepares the family to care for their infant at home and includes topics such as breastfeeding, kangaroo mother care, immunization, danger signs, infection prevention, and newborn development. Next. Research from the interview with caregivers, community health workers, and hospital staff highlighted the importance of involving families in the care of their newborns. And one of them is the program created transformative change in the unit, in the relationships between facility staff and infants caregivers. Previously, caregivers were not typically involved in the discussion about their infants' care. The program encouraged staff to spend more time connecting with each caregiver and learning about their home environment. This combined with group education classes, one-to-one teaching sessions, and supportive supervision of newborn skills enhanced the environment and increased the level of engagement from the families. Two, families and community members indicated changed beliefs about the ability of premature infants to survive and thrive. In Uganda, there are some cultural beliefs that premature babies cannot survive. By involving family members, including the father in education sessions at both hospital and at home, improved the likelihood of the family prioritizing funding for their child. Community health workers also play an integral role and are important to both the parents and hospital staff. Staff expressed that it gave them peace of mind to have someone in the community to fill the critical gap by providing follow-up care to small and sick infants. The study showed that the caregivers found the visits helped build their confidence as they helped to reduce parental anxiety and give parents an opportunity to ask questions The visits allow the community health workers to continue to educate the parents at home on topics such as identification of danger signs, immunization, child development, and referral for additional care when needed. Our community health workers have been trained to identify babies that are showing signs of neurodevelopmental disability and linked to our Baby Ubuntu program. This early identification increases early referral and intervention. We aim to bring these two programs as close together as possible. And in the next presentation, you'll hear more about the Baby Ubuntu program. Thank you. Over to Beatrice again.
Yes, thank you, Hilda. Since we began the program in 2019, approximately 3,500 infants have been enrolled in the program. We are excited to have a hospital at home package available for free on our online knowledge center. This package is targeted at health professionals or leaders working in hospitals in low resource settings who want to decrease the risk of preventable newborn death. It includes all the materials and instructions necessary for other facilities to implement their own hospital at home program. This includes guidelines of care, training packages, job descriptions, and reporting templates. As we continue to expand our work in Uganda, we are going to be working with the Ministry of Health and health facility partners to adapt and implement the program in a public setting. Last slide. It is therefore imperative that small and sick babies receive continued quality of care throughout their hospitalization and after being discharged home, and that parents are involved in the delivery of that care. Through hospital at home and family-centered care, we can ensure that parents feel confident and supported to look after their own newborn. Thank you very much for listening. I now invite Rachel Lassman for the next presentation.
Hello, thank you so much, Hilda and Beatrice. My name is Rachel Lassman. I'm a British trained occupational therapist, and I live and work in Uganda and have been based there for the last 10 years. I want to thank you for the opportunity to share the Baby Ubuntu program with you all today. Baby Ubuntu is an innovative early care and support program for children with developmental disabilities. And as you're all aware, often the small and sick newborns are more at risk of developing developmental disability. Globally, we have 53 million children with developmental disabilities, with the majority living in low and middle income countries. So supporting these children after discharge is of great importance. The need is high, and very often the access to rehabilitation and support services is low. Next slide. And the next one as well, please. Okay, so Baby Ubuntu is a 11 module participatory group program. It's co-facilitated by healthcare workers and expert parents, so parents of children with disabilities themselves. The themes running through the program include promoting inclusion and participation, maximising developmental potential, health and quality of life, and promoting caregiver empowerment through peer support and information sharing, and addressing issues related to stigma and human rights. The programme was developed in 2015 in Uganda in response to research done there. And it was developed in consultation with an expert panel and had parental input at all stages during the writing and piloting of the content. Next slide, please. So the program is available on the Ubuntu Hub website, and I'll pop that, or one of us will pop that in the chat for you so you can access that link. It sits within the Ubuntu Hub, Ubuntu meaning humanity towards others, and it sits with two other programs, Ubuntu for children 2 to 11 years old with developmental disability, Baby Ubuntu, which is for the 0 to 3s, and Juntos, which is for children with congenital Zika syndrome and has been used extensively in Latin America. On the hub, We have access to a shared community of practice and regular webinars as well for shared learning. Next slide. So I'm going to talk about the content of the programme, but I'm going to use pictures rather than lots of slides with words. So the group is participatory, which means when we're talking about a topic, we're actually doing it. So as it's shown in these pictures. So the content covers understanding disability and development, positioning, as you can see this little chap here lying on his front, practicing his head control, propping his head up, and this little girl here sat in her basin practicing her sitting. It covers feeding. We've got a picture of a father cup feeding his little one, play and stimulation, and everyday activities and stigma. And as you can see, the groups are very active and fun, and the children are centre stage during the sessions. Next slide. So the Baby Ubuntu package includes the manual, which is freely available online at the Ubuntu Hub. As I said, access to the shared learning platform, the forum, and regular webinars. We have developed a series of training to help new implementation partners support them on their journey to implement the programme. So we have a 3-day implementation and introduction workshop. We have a 3-day master trainer training for developing sustainability within an organisation or country so that they can continue to train facilitators without additional support. We have a 5-day facilitators training to train the healthcare workers and parents to deliver the group programme. And we have, for all of our training, ongoing support and mentorship. We're also currently developing a tablet application to help add more audio-visual content to the programme and help support fidelity of delivery. Next slide. So we have currently, since 2015, reached 963 families across East Africa with the support of our implementation partners. And we have 34 master trainers and 188 group facilitators. And as Hilda and Beatrice said, Adara is one of our implementation partners and has been working with us since around 2017, implementing the programme. We're currently looking at expanding the reach and coverage beyond East Africa. There is a programme being adapted in Fiji for high-risk preterms, and the University of Melbourne has adapted the programme for humanitarian settings, and it's called Mighty Children. And we're also working with South to North Learning with adapting the programme for the UK NHS healthcare setting. Next slide. So the programme is supported by a portfolio of evidence, including a feasibility trial showing programme feasibility and acceptability, and piloting and mixed methods evaluations, both in Uganda and Rwanda. Next slide. So in our mixed methods evaluation and early piloting across Uganda and Rwanda, we use the paediatric quality of life family impact module, and we rated caregiver quality of life before and after the intervention. And we saw between a 15 to 25% improvement in quality of life. And qualitatively, caregivers reported improved knowledge and skills and reduced stigma. Next slide. We then went on to conduct a randomized controlled trial looking at feasibility and acceptability, in which we recruited 126 infants, and this took part in Kampala and at Chiwoko Hospital with Adara. The early evidence of impact was didn't show a quantitative change in quality of life and function of the children, but qualitatively produced a lot of rich information about the impact of the programme, increasing caregiver skills and confidence. And we're about to start a larger scale impact evaluation in Rwanda. Next slide. So these are some quotes from our parents, which I think speak volumes. The training has helped me understand, and the thoughts of abandoning my child have ceased, and her life has improved. I no longer feel stressed and sad. We had a lot of fear, and we used to think that they were wasted children, but fellow mothers give us hope that our children can improve, and this has kept us strong. Next slide, please. So what we've learnt, I'm going to go through these last few slides quite quickly because of time. We know there is a huge demand for programs for children with developmental disabilities. We know that these programs need integrating into community health systems, and I think the Adara Home to Hospital and the integration there is a lovely example of that. We know that community and paternal engagement is vital for the success of groups. We know that poverty is a huge limiting factor, and we've been working on developing and strengthening livelihoods components that can be ran alongside the programme to help address that. And we know it's important to develop the capacity and skills of healthcare systems and staff. Next slide, please. So what we would like, our vision, is that we create an integrated approach to ECD and disability harmonised within government health systems, that we have a chance to provide transformative programmes, increasing social inclusion for families of children with disabilities, and that this programme is sustainable with high fidelity, and that the programme is accessible and adaptable across a variety of culture and global settings. Next slide. So Baby Ubuntu is a community-based participatory peer support rehabilitation programme, co-facilitated by expert parents, and it aims to provide a cost-effective solution for early care and support for our small and sick and high-risk newborns. Our feasibility trial have shown it to be feasible and acceptable in rural and urban settings in Uganda, and the mixed methods evaluation shows strong qualitative evidence of the impact, and that we need to embed interventions like Baby Ubuntu within government health systems. We know that barriers include stigma, poverty, and health system capacity, and are working to address those issues. And next slide. And I just want to say a huge thank you for the opportunity again, and to everybody who collaborated in developing and testing out and researching the programme. Thank you. Ellie.
Thank you to the panelists. I hope everything was heard and we learned a lot through this interactive seminar. Most of the questions have been addressed in the Q&A chat box. I can't see anything which is pending. Mita, do you have anything pending? I don't see anything. Most of them were responded to.
We have 4 questions, but we've probably got about 5 minutes to answer them. Any questions we don't have a chance to answer, we will come back to you with answers from the panelists. So there is... Yeah, I think we've pretty much covered all the questions. If there's any questions anyone has that you'd like to answer now, we can do this live. We've still got 5 minutes left.
This is our chance.
Mita, maybe I can just add here, just to say that quite a lot of the questions are from really rich thoughts, for example, from Natalie Charpak and John Wanena, offering resources. And we would welcome, the point of this toolkit is to share your resources. So if you have relevant resources, please do let us know.
Yes, sure, Professor Joy. Any burning question that you cannot sleep until tomorrow before being answered by the panelists? We have 1.5 minutes or 2. No, any last words from the panelists? Maybe we can start with Rachel.
No, I don't think I have anything else to add at this point. Thank you for such great presentations and such variety.
Okay, experience from Baby Ubuntu, Beatrice and their colleagues.
Yes, thank you very much. We don't have questions at the moment, but we are so excited for the opportunity given to us to share. Maybe I can give my colleague Hilda to say something.
Yeah, I'm also grateful for this opportunity that you've given us to be sharing our experiences, just encouraging all health facilities to take on the family-centered care approach in the care of the newborn. Thank you.
Beautiful, that's the way to go. From India, Dr. Vivek, we learned a lot and we wish to be there.
Yeah, Naya, thank you. I think, one big lesson that we are learning here in India is what we are trying to call is the inclusive approach in our ECD strengthening is to focus on the caregivers and parents of these small and vulnerable newborns that need special care. Their growth trajectories may also be different as we are learning and we are aware also. So some of these SNCU discharge clinics are also being trained on what we call inclusive ECD, that is to be able to empower parents and the frontline health workers to provide support for ECD to the special group of newborns and not just the normal newborns.
Thank you, thank you. Dr. Lewis, your first word was heard. What will be your last word?
Oh, thank you, Naya. No, just to say thanks to everyone. It's really lovely to see so many concrete examples of how it's being implemented all around the world. So just congratulations to everyone. And yeah,
thank you, everyone. Just not to miss our next seminar on the health system building block, and this will be on 25th July. And we will discuss more on medical supplies and devices. All these newborns sick, small and preterm, low birth weight, term babies, all needs the medical supplies and devices. How can we ensure this? You're most welcome, and we look forward to host you on the 25th of July. Thank you, panelists, and thank you, Mita, and thank you, Professor Joy, and everyone. Our translator on the background, thank you. We enjoyed your French translation, although we don't speak French for some of us. Thank you.
Thank you, Naya. Thank you, everyone.
Thank you. Bye.
Big thanks to everyone, and particularly to Mita. Thank you, Mita, and wonderful panel.
Thank you.
Thank you, everyone, for your participation. Take care.